British Shoulder Elbow Society. Night pain, passive elevation is that 100. And external rotation 1/2 of an. The X-ray should be. This is a patient, apparently normal looking X-ray, diagnosed with frozen shoulder, taken for manipulation anesthetic. On manipulation, developed a fracture found to be a secondary from the breast, as a case reported. So you can't take any case of a stiff shoulder as primary frozen shoulder and advise your own intervention. You have to rule out all the other causes. And these are the causes of frozen shoulder which have been implemented in this problem. Several things. Most of us we see diabetic patients and thyroid patients. A lot of surgery, post-heart surgery patients, post-cancer patients also come into this. Now recovery is always sure and maybe confidently expected is what Ordnance about 100 years ago, and we still tell this to our patients. Now residual restriction of motion in at least one plane is definitely important. This is something which you need to tell the patients as well. Now sometimes the patient comes and compares both sides and says the internal rotation is not as much as on the other side. I mean that's final limitation will be there. That might not be useful for functional range, but if you compare the two sides, there will be always some residual restriction in motion. Now, we know the stages starts with the inflammatory stage, then it goes to the frozen or the freezing stage, and then it thawing stage. Now you see florid inflammation and synovitis in the first stage, then the tissue becomes cartilaginous, it becomes very thick and hard. It's like a plastic. When you go in and you try to cut the MGHL and the CHL, it's very thick, it's almost like cartilage. That's the final stage where stiffness is the only concern, pain is no longer a concern, patient is not able to move the shoulder. Now imaging, these are the findings. You see the contracted axillary pouch, and then you see a lot of synovitis underneath the coracoid, just above the subscap, edema there, and you might see some amount of pasta, this and that, but you have to be very careful in doing a rotator repair in the patient as primary focus. Now secondary PA, you have to be aware of these patients. Many times in our settings, osteoarthritis is not common, and many times it is labeled as frozen shoulder. So you have to keep it in mind, take an X-ray before trying to label a patient as frozen shoulder. Now there are several treatment options. Usually physiotherapy is the first line. Now this is a recent article comparing as a systematic implement analysis. Beyond doubt, it has established that an intra-articular corticosteroid in the early, even up to 1 year of frozen shoulder has benefits. This meta-analysis of many trials. Now, how much steroid to give? You can give 20 mg or 40 mg triamcinolone. That's what's available nowadays, and there's no difference. I used to give 2 ml, which is about 80 milligram of triamcinolone with about 8 ml of. Now, this is the approach I do. This is an anterior approach. This is the best approach to enter the shoulder. You are always almost there. 70 to 80% accuracy if you do it blind, and you just go lateral to the coracoid. Insert your needle in this direction and you will usually enter the joint. Even if you don't enter the joint, the pathology is anterior. Rather than coming from posterior, you give your injection anteriorly, the injection almost always works. This is the study where they injected dye, and they found out about 70% of the time when they injected from the anterior aspect, they were inside the joint, and from the posterior aspect only 30%. Manipulation and anesthetic almost given up, very selective, very early cases can try. There is a risk of tear of several structures. Post-manipulation pain and stiffness is a definite concern. Now, arthroscopy is becoming increasingly popular. We have been doing it for some time now, and we've seen good results. Now, the one concern with arthroscopy is you might not be able to enter the joint when there is a very, very tight joint. Now, this is a very nice trick to do it. What you can do is you can enter from the superior aspect, go into the subacromial space. From the subacromial space, you can insert a blunt just anterior to the supratendon, and then you enter the joint. Then you put your sheath through that blunt, using your rod, and then once you are in the anterior aspect, under vision, you can do your portal from the posterior aspect. So this is one nice technique, trick which you can do. Now this diabetic patient injected once, MUA done outside, now presents with severe stiffness and tears. This is post-manipulation stiffness. There are several patients who actually have this issue. So when you enter the shoulder, you see florid synovitis, very thick capsule in the front. There is so much of capsular thickening. That's the MGHL and the capsule in the front. Try and remove whatever is thick and tight in the front. Completely RF. Hardly any use for shaver here because it's going to bleed if you use a shaver. You can use a punch. You can use a arthroscopic scissors if you have access to it, and you can go all the way down to the 5 to 6 o'clock position. Now I do a sort of a global release, releasing everything that's the coracoid. So I make sure that I make the coracoid naked almost, because your coracofemoral ligament is attached to that aspect. Underneath the CA ligament attachment is the CHL attachment. So the whole lateral aspect of the coracoid is made naked. So that's the release you have done from the front, and once you've done the release in the front, then you can move. Once you've done the release in the front, you can actually move the shoulder and see that the shoulder is nicely moving. There is a good exnotation now. Now, internotation is the most difficult movement to achieve in my experience. Many patients still have a little bit of internotation restriction. All the synovitis is liberated as much as you can, and then once that is done, then you go posterior. So you go all the way posterior, inferior you can see, and all the way right from the posterior inferior aspect to the posterior superior aspect, you can use the RF2. The capsule is not very thick there, it's a thin capsule, muscle is just underneath. So you can release the capsule posteriorly. Once that is done, then you end up having only the most inferior aspect of the capsule, which can be released by gentle manipulation after you take the scope out. Manipulation is not done before putting the scope in, it is done after taking the scope out just to get the movements. It's a very, very gentle procedure. Now I finish off always with the LHP T0. The LHP looks it's a synovitic and a subacromial decompression as well. And that's the movement you get in the patient. Happy patient, it's a complete movement you can get. Now these are other patients. So this is another interesting article. I'll just take 1 minute. This is severe loss of motion is what we study. There's an article from Pugaya's group. I urge each one of you to read this article. It's about 2,000 patients he examined, and what he did was he examined the exnotation in all the patients. So he didn't measure the exnotation only in standing position, but he measured it in the lying down position as well. When you measure the exnotation in lying down position, many times you can see that patient has a little bit more exnotation. So in the lying down position, if the patient has, you stabilize the scapula in the lying down position, so the scapula is not moving anymore. So you exactly know how much is the exnotation of the glenohumeral joint. So based on the exnotation of the patients, he divided this patients into 3 groups. The first group had severe global loss, 0 exnotation. The second group had exnotation up to about 30 degrees, and the third group had only mild to moderate. Now, all these patients underwent ultrasound of their shoulder. Now, the grade 1 patient, they were significantly younger and higher number of females, so they had only 1 degree of exnotation. The grade 2 had about 31 degree of exnotation. Grade 3 had about 49 degree of exnotation. Just keep it in mind. Now, when they did an ultrasound on these patients, the grade 1 patients, almost 91% of these patients had an intact cuff. The grade 2 patients had about half the patients had a cuff tear, and the grade 3 patients had almost 60% of the patients, 70% of the patients had cuff tear. So what basically the conclusion is, shoulder stiffness with severe ROF restriction is at the first visit likely, they are all likely adhesive abscess. You don't need to get an MRI. But patients who have less severe degree of stiffness, so they have 30 degree or 40 degree of exnotation, these are patients you might have to do an MRI to find out if they've got a cuff tear leading to secondary frozen shoulder. This is something you need to keep in mind. ER 0, no pain on elevation, or impingement is absent, then it is frozen shoulder. ER is 20 to 30 degree, painful on impingement, image early. Okay, they might have a cuff tear. So standing around is painful, tries to find, you can get manipulation. So rule out all the differential diagnosis for stiff shoulder. Gentle rehab, no heavy rehab, inject at the right spot, avoid manipulation. Arthroscopy is a good choice in recalcitrant cases. I thank once again for this wonderful opportunity, and I wish all of you the very best. Thank you.